Hello and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to go over something that I don't think the evidence as it stands is exceptionally strong in this direction, but it's something that I chose to investigate, or at least start to broadly look around within the research literature. So again, keep in mind that this is not something that I'm saying, this is exactly what's going on. It's the attempt to share the process of joining pieces of information with a semantic network or with a network of related meanings. So essentially, things that are previously known, you're taking a new piece of information, and you're starting to work it together. You have to acknowledge that when you do this, it can feel like a eureka moment, it can feel fantastic, but it could be leading you down a silly path. You could be making an error that you can't detect because the information is too early, too new. You can have a strong conviction because it's like, well, these pieces of information fit together really well, so it has to be correct. It doesn't have to be. I want to put this out there because it's something that's developing for myself that I'm going to look at more to try to understand some things. Now, I have an obvious preference for the theory of constructed emotion. The theory of constructed emotion put forth by Dr. Lisa Feldman Barrett and many, many colleagues, but primarily Dr. Lisa Feldman Barrett as the person whose namesake would be on it. What it's doing is it's looking at large amounts of seemingly strong neurological data and combining that with how it impacts affect, or essentially general mood state, so positive affect or negative affect. So positive being what would often then be related to positive emotions, negative affect being related to negative emotions or negative states, things along that line. So there are many sensory surfaces in the body. They will send information to the brain. The brain will interpret primarily based on previous experiences or previous interpretations. And then you have affect. So you will have variation in observable physical signals that lead to the output of a particular word that will relate to what would commonly be considered an emotion, or a word that describes an emotion. Because it's the same word, the common previous approach was that we use the same word, therefore it must be the same things, therefore there must be a stable signature. What we've seen to have found is that you have a category word, be it anger, happiness, joy, sadness, depression. Those words have a wide variety of physical signals related to them, whether it's skin conductance values, heart rate, respiration, perspiration, things along those lines. And there's a variety of those that will then turn into the report of one word. So one word is experienced different within the same person, or is generated from varying physical states in the same person, as well as varying physical states between people. Therefore, it's really more about the interpretive step for that particular individual and then how they choose to communicate it. This can be seen partially through the observation that some cultures have words for certain states that other cultures don't have. Some cultures, the one that Dr. Lisa Feldman Barrett talks about quite a bit, I think it's somewhere in the South Pacific, there's a culture that when there is uncertainty or distress, their answer is to have a nap because it'll help you process it, right? So when you're stressed out, the answer is nap. Whereas in North America and a variety of cultures in other places than that don't seem to have that. There are emotional words that are not expressed in every language or in every culture. Therefore, there is no category with which to place them in a particular language or culture. So that variance becomes important to say that there is some cognitive step, there's some interpretive step that is done in relation to obligate physical signals. So lots of rambling there to try to refresh what I've said for myself and for you who are listening or watching about theory of constructed emotion. So what the heck does this have to do with anything? Well, I was filming a course or filming a workshop that a colleague was putting on who was talking about hypermobile patients. I will say because I want this out there. I want my preferences known. I don't like to say biases. I want sort of my angles known. I tend to see what are trends in hands-on manual therapy and the interpretation and the things that are grappled with. So the first trend that I saw in not necessarily hands-on therapeutics, but complementary alternative medicine was leaky gut syndrome. Then that, as a result of that leaky gut, you see interpretations where, okay, well, a vegan diet or an elimination diet, then you start to see paleo, then you start to see keto, then you start to see carnivore, and you see some trends. You see a lot of people grappling with the information in the public sphere and going through that. So a similar phenomenon that I see is hypermobility. I see a similar phenomenon specifically with respect to lots of people speaking about Ehlers-Danlos syndrome, then speaking about POTS, or I believe it's postural orthostatic tachycardia syndrome. Now, if I'm misinterpreting that, it's on video. So I may be making an error that I'm not aware that I'm making, but I'm at least aware that blowing the acronym out, I could be screwing up. I can just check my phone right now, but whatever. I'm okay with making the error. Then you have MCAS, or mast cell activation syndrome. So essentially you have what seems to be a description of autoimmune conditions that are causing certain expressions. With Ehlers-Danlos, you have an autoimmune condition targeted at soft tissue. So you have things that would be described as, boggy heart. So the pericardium actually has a lower amount of tension in it as a connective tissue, and the heart isn't necessarily as well contained. Now, the heart rate, what that would do to how the heart is functioning and the sensory information from the heart, it would actually probably increase, or you could predict that it would increase signals from the heart about essentially an abnormal state. So my colleague was talking about this. My colleague did note that in literature regarding Ehlers-Danlos, people who are diagnosed with it are known to have what is called a fuzzy body map. So they're not necessarily seemingly as neurologically aware of joint positioning, body positioning, things like that. So what that did in my brain, because of my semantic network or my network of related meaning, it turned into the word uncertainty. Turning into the word uncertainty with respect to neurological issues then popped the term theory of constructed emotion into my head. It seems as though the research that underpins the theory of constructed emotion points to higher levels of uncertainty relating in the general direction of more negative affect. So when things are uncertain, you seem to be more stressed, you seem to have more negative affect. The other thing that was happening during that workshop was many of the people who were very interested in working with hypermobile patients seemed to either be reporting from the experience of their patients or their clients or themselves, and they talked quite a bit about the sensation of being unheard by medical professionals or unseen by medical professionals. And then that did a little bit more because of personal experiences and sort of made me think again in the direction of there are internal states that other people cannot appropriately observe. So that made me think of things like nociplastic pain. There's no possible or actual damage identifiable to tissue, no pathology of nerves, but the person's reporting discomfort, they're reporting pain, they're reporting negative sensations. So it started to kind of coalesce in my mind and say, hey, is there something in general literature that talks about relationships between autoimmune conditions and personality disorders, or autoimmune conditions and psychological disorders? So I popped up good old Google Scholar, and starting in sort of the mid-2000s, so 05-ish, I think I saw something from 02, and this is a really, really general search. It's autoimmune disorders and personality disorders, or autoimmune conditions, maybe it's autoimmune conditions and personality disorders, because sometimes when you change the Boolean terms, what pops up is a little bit different. But I had done this specifically for Ehlers-Danlos and personality disorders, and I saw some stuff. I looked at the Ehlers-Danlos website. So there is an association, an Ehlers-Danlos Association. They maintain a website, and they do have some very broad information saying that there is early research suggesting that there may be a relationship with Ehlers-Danlos and personality disorders and psychological stuff. I think from memory, and again, I'm not looking at something right now, but I think from memory, it was speaking about borderline personality disorder, which is a cluster B personality disorder. I have personal experience with cluster B personality disorders in people that have been around me. And there's patterns that I think I see, but because I think I see them, I have to be even more cautious because I, as the observer, could be the problem. But then I looked up autoimmune disorders more broadly and personality disorders, and there's at least research that's trying to tackle that question, the degree to which there's co-occurrence. So what it does, all of these things come together to, under the heading for myself with what I know, not what I know, what pieces of information I have exposed myself to, thought was important, and remembered, under the term theory of constructed emotion. I've heard some psychologists say psychology is biology, and if you don't agree, then you just don't understand either. Now, I'm not going to pick at the strength, weakness, validity, veracity of that statement, but it is an interesting thing to hear from somebody who has clinical experience with psychological stuff. So there seems to be more and more information pointing to fundamental biological processes, specifically trackable through neurology, and then the expression, the subjective report. So there's something going on, seemingly, with higher degrees of internal uncertainty or higher degrees of internal signaling, and then cognitive processing. What you seem to see is that people with physical stuff going on that isn't easy to observe, so far, very, very superficially, what I can spot is CBT, or cognitive behavioral therapy, seems to do something positive. Now, cognitive behavioral therapy maybe could really roughly be described as taking the same piece of information. It's like a Gestalt shift, taking the same piece of information and looking at it from a different angle. So reinterpreting the signals. So it is much more costly metabolically, apparently. This is described by the theory of constructed emotion and Dr. Lisa Feldman Barrett. It is more metabolically costly to respond to something in the moment than it is to predict, right? So one of the reasons cognitive behavioral therapy seems to possibly have a positive impact is because more often than not, we're going through patterns of prediction based on previous experience with respect to a specific stimuli. So if that specific stimuli shows up over and over and over, and what we're able to do is cognitively interrupt the interpretation, it is costly metabolically, it is difficult to do, it's not easy, but over time, we turn that new angle, that new interpretation into the more consistent interpretation, and then under the same stimuli, you seem to be able to have lower levels of uncertainty, lower levels of negative affect. So you can turn that thing into a different subjective experience. So, and again, it's all sort of sewing together, whereby instead of looking at the specific condition, the specific syndrome, so Ehlers-Danlos syndrome, POTS, mast cell activation syndrome, whatever, whether it's lupus, whatever autoimmune disorder, if the commonality seems to be that there is some psychological and emotional presentation, very generally, not specifically, not the same presentation, not the same stuff, but this generally people with autoimmune disorders seem to have more negative affect, then maybe if we shift our level of questioning or our direction of questioning or angle of questioning to what I see is already happening, to the co-occurrence of autoimmune disorders and personality disorders or psychological and emotional stuff, right, or conditions, then if we see some consistent presentation of those, then it might allow us the opportunity to do an effective job assuming very little and explaining a bunch by noting that the internal sensory surfaces are getting more information more often that seems to be easily interpreted as negative. Therefore, you see more negative affect in people with autoimmune disorders. We can then, even if we don't properly understand the exact mechanism of how that works or how interventions work, we might actually be able to sort of relate that to nociplastic pain as a category and say, you know what, psychological and emotional interventions may be most appropriate for these individuals, along with other things. The psychological and emotional aspect. So I obviously have critique of the biopsychosocial model. It's sort of a no-duh. Yeah, there's biological, psychological, and social factors that impact somebody's subjective experience or somebody's pain expression. But to not be dismissive and to say that there may be circumstances whereby if there's a co-occurring autoimmune condition, an individual is going to have more sensory information that is either can be described as uncertain or negative, and you start to see some stuff, and no matter what you do as a practitioner, it doesn't go the right direction, you can start to say, well, the limit of my intervention may not necessarily live in the realm that's going to help you change, so I can identify that's my barrier, or that's the end of my skill set, the end of my road. So the psychological thing may be appropriate, and really what it seems to be is primarily reinterpretation of consistent signaling. I don't necessarily know the specific answer there. I just think I'm seeing a phenomenon. I think I'm seeing that nociplastic pain is a great term, great category, because it opens up new angles of inquiry, and that the theory of constructed emotion does a really good job of assuming very little and explaining quite a bit. You have sensory information going. You're primarily predicting based on previous experiences. So if you have a negative interpretation initially and you continue to have a negative interpretation, there you go. And you seem to be able to get some mileage out of something like cognitive behavioral therapy, which is more or less really roughly reinterpretation of the same piece of information. So you have a piece of information A and interpretation 1. Well, now you have interpretation 2 or interpretation 3. And that seems to do something. So there's an avenue there. There's an angle there that a lot of these things seem to coalesce around that I think has value. I do see superficially research in that area. And I'm saying this out loud, partially to be early on explicitly sharing my thought process, as well as early on saying, I think it's valuable to look maybe more broadly at autoimmune disorders and psychological, emotional, or personality disorders as something that is related, and it may be easily related on higher frequencies or higher incidence of uncertain neurological signals being interpreted as uncertain and relating highly to negative affect. So I happen to have experienced quite a bit people with difficult to identify subjective complaints. They don't seem to match the physical presentation particularly well, and they do seem to have more negative affect, right? So depending on you as a practitioner, you could easily interpret that as a difficult patient, a patient that's not for you, a patient that's negative, right? And that may be coming from a place that as hands-on practitioners, we can't find. We can't find the autoimmune disorder. We can't find that thing. So it's outside of our purview to identify, outside of the fact that when we find restricted motion, we treat restricted motion, and the person still has the same subjective report, that could indicate that there's another sphere that we could send them into that's outside of our skill set. So I've said before that I don't think the biopsychosocial model does much more than tell an osteopathic practitioner or a massage therapist or a physiotherapist or a chiro that the sphere that the issue the patient is talking about or reporting is in a sphere that is not the one that I can properly deal with. It's not properly related to mechanical dysfunction. I can treat the mechanical dysfunction all I want, and they're still going to feel the same. They're still going to report the same thing. So The biopsychosocial model more or less tells you the edge of your effectiveness, the edge of your skill set, the end of your road. And I think that there may be a hyper focus based on my experience on specific conditions. I think they're a little trendy. It sounds dismissive to the people that are experiencing them. And I'm trying to actually not be dismissive. I'm trying to be more broadly inclusive and say, you know what? There might be a lot of people with mild autoimmune disorders or major autoimmune disorders that are exceptionally hard to diagnose, that are having sensations that they feel like nobody's paying attention to because nobody can find them, especially not hands-on practitioners and especially not doctors, because it's not what they're looking for. And we just don't have it in our paradigm. But I think that the theory of constructed emotion is a theory that assumes very little, explains a lot, and can start to unlock this realm or this angle of understanding that might end up being helpful. So instead of it sounding dismissive to say that a lot of the discomfort that somebody's feeling is in their head, quote unquote, or psychological, it actually may be empowering to say, you know what, you do have way more uncertain physical internal signals, internal neurological signals that you're interpreting in a negative direction, but we might actually be able to help by training you over time with great difficulty and a lot of metabolic expense to reinterpret this as maybe it's normal for you, it's not particularly dangerous, and you can improve with this type of intervention. So it can sound dismissive, but it could also sound empowering. And I don't know if I'm doing a good job at the moment negotiating that line, but I actually think it might be empowering. And it might be empowering for practitioners to say, you know what, it may not matter which condition this is. It may matter that I can say, hey, if I'm having a positive impact on you in some way, I'm happy to continue. But I think there may be some place that you get more mileage from that could be an effective psychological intervention or an emotional intervention. So lots of rambling. Thanks for sticking around this long. It's been a pleasure talking. Hopefully you've learned something from this, and we'll talk again soon.